Dr. Junkins is our head of microbiology here at Norton Healthcare and has been a tremendous partner with the infection preventionists, the pharmacists, not only within Norton Healthcare system, but really has been of tremendous help to us and has been a presenter several times for infection preventionists across the Louisville area and beyond. So I'm really appreciative, Dr. Junkins, of your time today. So let me turn it over to you while you give us the lowdown on C. difficile.
Okay, thank you very much, Ruth. Am I good? I'm unmuted? Great. Okay, I'm good. Okay, good afternoon, everybody. Yeah, I decided it was time to tackle C. diff. I don't know. I've missed some of these presentations, so maybe somebody's talked about C. diff, but C. diff is kind of like one thing that we spend an awful lot of time on. And I just thought, we should kind of get into it because from a microbiology perspective, this is a really tough nut to crack. In fact, I'm going to start with the conclusion. There is no great laboratory test for diagnosing C. difficile disease. I originally said there is no good laboratory test, and I decided that's pushing it a bit too far. There are some good tests, but there's no great test. There's no test that really tells you this patient has C. difficile disease. There's a lot of other stuff that has to go into play with it. So we're going to go through some of these tests that have been available and are available now. And kind of talk pros and cons of each one. Let me start off with the name of the bug. Forget the Clostridiodes part now. We can talk about that later. But difficile. It was called difficile back in 1935 because it was hard to grow. It grew very slowly. It was a difficult bug to deal with. And out of now over 80 years since this bug first came around, not much has changed. It's still a difficult bug. We don't grow it that much, but it's still difficult to deal with. So here's the problem. First of all, C. diff is normal flora. A lot of people have this bug in their gut, not causing any problem whatsoever. The rate of asymptomatic colonization can range from only maybe 5% in non-hospitalized adults, people who are around doing their business, just haven't been in the hospital system or any healthcare system for a while. About 5% of them are colonized with C. difficile. In infants and children, it's much higher, especially in like a NICU setting. 70, 75, 80% of patients in a NICU setting are going to be colonized with C. difficile. Other young children will be colonized with C. difficile, and the rate tends to drop down a little bit every year. Once they get to be about 4 or 5 years of age, it's about the same rate as it is in adults. Once you get into people who are hospitalized, quote, several times higher. So you can easily see in your hospitalized patients, 25, 30, 40% of those are just colonized with C. difficile, not causing the disease, just colonized with it. Another issue is that the bug itself is not causing the disease. What causes the disease is toxins that the bug produces. There are two of them that we really care about, toxin A and toxin B. Toxin B is probably the most important one because we know we have seen patients who have had C. difficile disease that were not producing toxin A, but they've all been producing toxin B. So we think toxin B is really the one that's most important. But a big issue is that not all strains of C. difficile produce toxin. Based upon data that we had from years ago, I would say probably about, in our area, 40% of the strains of C. difficile that we detected were not producing toxin. So if you're colonized by one of these bugs that is C. difficile but is not producing the toxin, you will not get C. difficile disease. It has to have the toxin. So there's an awful lot of C. diff out there that is basically, as far as we're concerned here, non-pathogenic, not going to cause disease. So really, if you look at patients, you've got 4 possible states that they might be in. You have people who are completely uncolonized. This is going to be the majority of non-hospitalized adults. Obviously, if they are not colonized by C. difficile, they do not have C. diff disease. There's no bug there. There's no toxin there. That's pretty straightforward. But then you'll have a significant portion of people who are colonized, but with a non-toxigenic strain. It doesn't produce those toxins. So you're not going to have C. difficile disease. you probably won't have much bug, because think about it. We typically associated this with disease after you've been exposed to antibiotics. Those antibiotics tend to clear out the competition a little bit, let C. diff grow better. He's not a very good competitor in the gut. So non-toxigenic strains sitting around there in the gut with all the other normal flora around, he's probably not going to get to a very high concentration. So you won't have much bug there. And of course, since he doesn't produce toxin, you won't have any toxin there. Then you get a whole bunch of people who are colonized with a toxigenic strain, but they do not have symptoms. So do they have C. difficile disease? Do they have C. difficile disease? No, because you have to have symptoms in order to have the disease. So there's probably not a whole lot of bug there. And there's probably very little toxin there. Even though it's capable of producing it, it probably not making a whole lot. But then you have these people down at the bottom, symptomatically colonized with a toxigenic strain. So yes, these are the people who have C. difficile disease. The bug has probably overgrown a little bit, gotten to a population higher than it normally gets. So you're probably going to see a lot of the bug, and you're probably going to see a lot of the toxin. Now, what causes the disease? The toxin. So if you really want to specifically diagnose disease, what we want to detect is toxin, and really kind of fairly heavy concentrations of toxin. But the problem that we run into is that all of this is a matter of degrees. Where are the cutoffs? How much toxin has to be there in order for it to be consistent with C. difficile disease? The other issue with this is, do you care about all these kind of categories? Do you want to put a patient into one of these 4 categories, or are all we concerned with is detecting C. difficile disease? And the reason I bring that up is, as we go through these tests, you really got to be careful as you're reading the literature, reading the information about some of these tests, is what are they trying to detect? You know, are they trying to detect that the bug is there? Are they trying to detect that the patient has disease? What is it that they're trying to detect? So let's go through some of these tests, and we'll start off with the 2 classical methods. These have been around for decades. You'll often hear these referred to as the gold standard test. I don't consider them gold standards. I think they're gold standards in that they've been around for a whole long time. They're the grandpas of all the tests that we do, but not necessarily perfect, as we tend to think of with a gold standard. So there's a cell cytotoxicity neutralization assay where you're going to try to detect toxin directly in the stool specimen. And then there's a toxigenic culture where you can grow the organism and then show that the organism produces toxin. So let's go through those 2 fairly quickly here. Here's the cell cytotoxicity neutralization assay. You start with a poop specimen. And of course, you really want this to be diarrheal, but what you do is you add some diluent, some saline or something to it to loosen it up a little bit. Mix that up really good. Then I'm going to centrifuge it, spin it down so I get all the particulate matter down here. And I've got this kind of hopefully semi-clear fluid up at the top. We run that through a 0.45 micron filter. That's going to get rid of all the bacteria. So all I'm getting is the extract, the chemicals, the compounds that were in that specimen. And then we're going to apply that to a microtiter tray or some kind of a plastic tray with cell monolayers in it. And you can use all kinds of different cells. I know if you're not into this, you know, we purchase these already made. They're layers of cells down on these plastic dishes. And then you watch to see what happens to those cells. So for example, this right here, panel A, is a picture of good, healthy fibroblastic tissue culture cells. That's the way they're supposed to look. But if they're acted upon by a cytotoxin, if the cytotoxin kills them, then they're going to round up, they're going to detach from the plastic, and they're going to look kind of like this. So what I would suspect is if my patient has C. difficile toxin in that stool specimen, then the cells that start off looking like panel A are going to end up looking like panel B. Now, seems fairly straightforward, but it really is quite complicated because you have to look to see, are there any other things? You can imagine in a stool specimen, there's a lot of stuff that could kill those tissue culture cells, not just C. difficile toxin. So you have to specifically demonstrate that it is C. difficile toxin that's doing the deed. So let's take a look at some samples here. Here's my stool extract. That's what I made from the patient. And when I apply that to a tissue culture cell line, there's no cytotoxicity. It doesn't kill it. We're kind of done right there. There was no cytotoxicity in that specimen. It's negative. But there's other things that can cause it. For example, this one here, we did see cytotoxicity. This is a toxin positive control. So this is where I'm actually putting in something that's got toxin. Okay, so that's got to be positive to show that my cell line is susceptible to this toxin. These two show that other things that I put in, what I used to dilute that stool specimen or just plain serum does not cause cytotoxicity. So you can see here that just plain serum is causing cytotoxicity, which means I can't interpret that one at all. I put that one in just to show you that it gets a little bit more complicated than just, do I see cell death or do I not? Now you look at this one, the stool extract killed the cells. But if I mix my stool extract with antibodies down here, antitoxin, antibodies against C. diff toxin, I still see cell death. So that tells me it's something in that stool specimen that is not C. difficile causing the cytotoxicity. And so that one is called negative. Whereas if you look at number 4 over here, the stool extract killed the cells, stool extract with plain serum killed the cells, but stool extract with serum that contained antibodies against the toxin did not. That's where we say we got C. difficile toxin detected. So it's kind of an involved assay. But we look at what's good and what's bad about this. First of all, this is the only test out there that actually detects the true cause of C. difficile disease, and that is toxin activity in the stool specimen. There are other tests that detect the toxin itself, the structural toxin, but this is the only one that actually detects toxin activity. It's the one that really tells you there is active toxin in this patient's stool specimen. The sensitivity is very good and the specificity is very good. So you would look at that and say, this is the perfect test. This is the one everybody should be doing. But look over here. You've got to have tissue culture facilities. You know, not many hospital laboratories ever had tissue culture facilities. Those of us that did, many of us have given that up. We do not have tissue culture facilities here anymore because we don't do viral cultures anymore. You know, viral cultures, it's all gone to molecular. So we don't have tissue culture facilities anymore. We couldn't do this test. It's expensive. It's labor intensive. It takes somebody a lot of time to set it up and to interpret it and all that kind of stuff. It takes at least a day or two to actually run the test. And you're not going to run it on demand. You're going to batch it. So you're going to set it up once a day, or you're going to set it up once every couple of days or something. So your turnaround time is going to be stretching into 2 days, 3 days, 4 days before you get results back. And I think most of us would agree that when a patient shows up in your hospital with symptoms of C. difficile disease, you don't want to wait 3 or 4 days to get the answer. You want the answer quickly. So how many hospital labs do this test to diagnose C. diff? I don't think there's any. You know, you can send it out to a reference laboratory to do this, but I think hospital laboratories have pretty much dropped this test completely. I don't know of any hospital that does this test. Then there came toxigenic culture, which is theoretically a little simpler. You take your stool specimen and we streak it out onto a medium that's specifically designed to grow C. difficile. Now, other bugs will grow, but you'll get these nice colonies here of C. difficile if the patient has it. That's got to be incubated anaerobically. It's an anaerobic organism. But once you've got the bug growing, that doesn't really mean anything. You still have to be able to show that it's got toxin production. So what I've got to do is I've got to take those colonies. I've got to find out that it really is C. difficile. And I can do that with biochemicals. I can do that with MALDI. I can get some hints about it as far as morphology goes. It's a big gram-positive rod. And odor. It has a barnyard odor. Now, for someone who's been around lots of different barnyards, I know that different barnyards smell differently. This is really supposed to be horse manure kind of barnyard, not a pig farm or a cow farm. It's a horse farm. So it's got that certain odor to it that helps out a bit. So identify it as C. difficile. then I have to demonstrate toxin production. I'm going to have to put it in a broth. I'm going to have to grow it up again and take an extract of that broth and do the same cytotoxicity assay we just talked about, or possibly just do antigen testing as well, be a little simpler. So what's great about this, you should have good sensitivity to detect the bug. The bug. I say should because, you know, my personal experience with it is we were not very good at culturing C. difficile when we tried to do it. So different labs may have different levels of success with that. And plus, once you've got the bug, and you can do other things with it. You don't really need to do much susceptibility testing with C. difficile usually, but you do have it available if you want to do genotyping. So kind of see, we look at the spread of C. diff through our hospital. The specificity to detect disease is not very great. You're not demonstrating toxin in vivo. You're growing the bug. You're not showing that there was actually toxin in the stool specimen. You're just showing that there was a bug that is capable of producing toxin. It's also labor intensive. It takes days, sometimes 5-6 days to get a result. And like I said, there's going to be some lab to lab variability. So how many hospital labs do this to diagnose C. difficile disease? I don't know of any. You know, some places will try it. We used to try it, but it's kind of been dumped. So those are the two gold standards. Then we jump into enzyme immunoassay. These became available a couple decades ago, probably. This is where you're looking immunologically to try to detect toxin in the stool specimen. So I take an extract of stool, I put it into these wells, I expose it to antibodies against the toxin that are labeled with an enzyme. I let that react, wash that out. Then I add a substrate where that enzyme is going to act on a substrate that will change colors. And I watch to see the colors show up. So I know that where I see yellow in here, that means there was C. difficile toxin in that stool specimen. So what's great about this, first of all, it's a kit. You buy it. It comes with everything that you need. It's all standardized. If I do it at my lab and they do it at U of L and they do it at UK, we're all doing the exact same thing. It's FDA cleared. It's gone through the FDA. The FDA has agreed that it works well. So it's nice. It makes us feel good about what we're doing. The specificity is very good. You're detecting toxin, and that should be what you get with it. Much less expense than what you get with those other two. It's easy to do, and it takes really about a few hours to get done. But what's not good about it? The sensitivity is not good. Most of the studies that looked at it showed sensitivities around 50, 60, 70%. In fact, remember back not that many years ago when we were doing this test, we used to tell doctors C. diff times 3. What that means is I want 3 different stool specimens collected at different times. Don't assume your patient is C. diff negative until all 3 of those come back negative. Now, that didn't happen very often. You know, a lot of times you just got one and that was the end of it. But the sensitivity was pretty poor. So we said, you know, you really need to do multiple specimens before you can be certain. You're going to batch that. That's going to be done once a day. So even though it can be done in a few hours, it's really going to have a turnaround time more of 24 hours to get done, which is not too bad compared to those earlier tests, but seems way too long for us now. And it did require a lot of hands-on time, and you had to be very careful with it. It was easy to mess up if you weren't careful. So how many labs do this test to diagnose C. difficile disease? Well, pretty much all of us used to. I mean, this was the way to do it. And we jumped on this. Instead of having to do cytotoxicity or culture, we said, bam, this is the way to do it. And so we all kind of switched to this. But not many still do. It's out there. You can get it. You can perform this test, but not many places still do it at all. Let's make it easier. Along came immunochromatographic assays. Now, this is doing pretty much the same thing, using an enzymatic substrate to detect an antibody reaction, antibodies against the toxin directly in a stool specimen. But instead of having it in that microtator plate and having to do all the washing and everything, it's in a cute little pregnancy test. like this. You take your stool specimen, you mix it with a little saline or something, you put some drops in this well right here, and then you watch for the lines to show up. This test line means, yes, I detected C. difficile toxin. Much, much easier to do, a whole lot easier to do. It's much faster. If a stool specimen shows up in the laboratory at 9 o'clock in the morning, the result can be out by 9:30. It's going to be done on demand. We don't need to batch these. We don't want to batch these. We want to do them as soon as they come in. So instead of saying we're going to have 24-hour turnaround time, you got maybe 30 minutes turnaround time. Much easier to do, much less hands-on. Saves you a lot on staff, not having to put in the time to do that test. Sensitivity is not any better. It's not any worse, but it's not any better than the old test. So you still have that situation of not being able to pick up everybody who's got toxin. Then came another advance to this where we added GDH. GDH stands for glutamate dehydrogenase. That is an enzyme, obviously, but it is an antigen that is produced by all strains of C. diff. They all make it. Even those that don't make the toxin will still make GDH. And these assays pick up GDH with much better sensitivity than it picks up the toxin. So here's one test, for example. Here's the antigen. This is GDH over here, and here's the toxin on the right side. You can do both at one time, or you can have separate cards that do the two different toxin and antigen. The GDH, the antigen, has very good sensitivity. Sensitivity is almost as good as PCR is. But the specificity is very poor because all of those non-toxigenic strains are still going to be positive for it. The toxin, on the other hand, is very good specificity. If you get a positive toxin result, you know there's C. diff toxin there. But as we've already mentioned, the sensitivity is very poor. So you've kind of got a mix here. And that led to interpretive charts, kind of like this one. If you did a patient and you had a positive antigen and a positive toxin, you've got the bug there, you've got the toxin there. No question, that's going to be interpreted as a positive test for C. diff disease, okay? If it's negative for both, I have a very sensitive test that's telling me there's no bug there, C. diff negative, okay? I'm not going to say anything about negative, positive for toxin because that hardly ever happens. We've never seen that happen. But you get this a lot, positive for the antigen, negative for the toxin. And that's the tricky one. You don't know what that means. It could be that they are colonized with a non-toxigenic strain, which means they don't have C. diff disease because a non-toxigenic strain is not going to cause C. difficile disease. Or it could mean that it's just a false negative toxin or that it has a low level of toxin that is below the limit of detection, in which case, is that associated with disease? Do we think that's disease or is that not disease? Or is it just colonization? Still don't really know. Then along came the PCRs. Of course, we had to get PCR going with this. These are just some of the instruments that will do C. diff PCRs. There's a whole slew of possibilities out there. And these are all very good, very good. Here's what's great about them. Very best sensitivity for detecting the organism. I think it's better sensitivity than what you got with the toxigenic culture. It's really good sensitivity for the detecting the organism itself. All of these, you're looking for specific gene target, and the gene target that was selected in most of these was the toxin B gene. There was one company that has it against the toxin A gene for some reason. But they detect the toxin genes, which means that those non-toxigenic strains will be negative. So when we say we detected C. diff by PCR, what we're saying is we detected toxigenic C. diff that is capable of producing the toxin. If you're one of those 40% that have a non-toxigenic strain, you're going to be negative by the PCR, okay? They're easy to do. I know molecular, years ago, molecular was kind of looked at as being kind of the sexy part of the laboratory. You had to get your really best techs into molecular. Molecular's easy these days. It's much easier than anything else in micro. And some of these are on demand, can be done as soon as it comes in with a turnaround time of an hour or two. Others are meant to be done in batches. So you run them once a day. So you're going to have a turnaround time somewhere around 24 hours. But here's the problems with them. You're not detecting actual toxin. You're detecting the bug. So the specificity for detecting disease is not very good. Specificity for detecting the organism is great, but specificity for detecting the disease is not so hot. It will be positive in patients who were asymptomatically colonized with toxigenic strains, which means your patient comes into the hospital, gets diarrhea because they're taking crazy drugs. If they were colonized with C. difficile, they're going to come back positive here, even though C. difficile is not causing their symptoms. Expense is okay. Expense is not bad at all. It's a little bit expensive than the EIAs, but it's certainly not too bad. So for example, let's take these 4 patients here. Here are their histories. She just came in with some diarrhea problems. He was in for cancer workup, car accident, community-acquired pneumonia. She got antibiotics. He got antibiotics. There's no mention here of antibiotics, but he got some medicines. All of them had diarrhea. All of them were tested by PCR, and all of them were positive by PCR. But only one of these patients actually has C. diff disease caused by C. difficile. Which one is it? And you don't know from the PCR. You don't know from the PCR. So let's look at this article. When this article came out now 7 years ago, it caused quite a stir. What these people did is they took people who were PCR negative or positive and toxin negative or positive and divided them up into these 3 groups here. So negative for both, positive for the PCR, but negative for toxin, and positive both PCR and toxin. And then they looked at complications of C. difficile disease. And what they found was this. Patients with a positive molecular test result and a negative toxin immunoassay test result had outcomes that were comparable to patients without C. difficile at all. So people who were negative, and people who were positive by PCR but negative by toxin were really much the same. They didn't have their characteristics, their disease course really didn't change any. The people who had complications and deaths related to C. diff were those who were toxin positive. So their conclusion is that if you're running PCR and only PCR, then you're going to be overdiagnosing and overtreating patients for C. difficile. And that became an issue, not just from a healthcare perspective, but as many of you know, from a financial perspective, and having too many C. difficile healthcare acquired infections. So along came the algorithms. We kind of started with these algorithms here, starting off with the simple GDH toxin EIA. If that was positive for both, the patient had C. diff. You're done. If it was negative for both, the patient did not have C. diff. Remember, I got a very specific toxin assay. So we know you had toxin. And then we have a very sensitive GDH assay. So if it's negative, we know you don't have C. diff. Okay. The problem came when they were positive for GDH and negative for toxin, and we could follow that up with PCR. And if it was positive, you had a toxigenic strain. Because in this case, remember, in this case right here, I don't know whether that's a non-toxigenic strain or whether that's a false negative toxin result. The PCR is letting me know. The PCR says, if it's positive, you have toxigenic C. difficile. If it's negative, you have a non-toxigenic strain. So this became very popular to do. And more recently, we've gone to a reverse algorithm step, where what you do is you start with the PCR first. If it's negative, you've got the most sensitive test for detecting the bug right there. If it's negative, you do not have C. diff disease. If it's positive, then we do an EIA for toxin. It can be one of those little immunochromatographic assays. If that's positive, now I've got detectable toxin, and I say we have C. diff disease. If it's negative, well, I know you've got the toxigenic bug, but you do not have enough toxin for us to detect. So we're going to say that that is most likely asymptomatic colonization. Now, the patient hopefully still has symptoms of disease, but most likely caused by something else. So those 2 algorithms have gotten to be really quite commonly used. So now we can look at this and say, okay, all these people were PCR positive, but when we did the toxin test, she was the only one that was toxin positive. We're going to say she's got C. difficile. It may have been just the drugs he was taking. She had salmonella. He had something else. But remember, these people, even somebody who's got salmonella, if they're colonized with C. difficile, then that PCR is going to come back positive, even though it's salmonella that's causing the symptoms. So now we basically have these 4 things that are being done in almost all hospitals. Either just an enzyme immunoassay for GDH and toxin. Some places are doing straight PCR for a toxin gene. Some places are doing an algorithm where you start with the GDH toxin and then follow that up by PCR if it's discrepant. And some places are doing the reverse algorithm where you start with the PCR and then follow it up. The advantage of the reverse PCR, even though it's more expensive because you're doing the more expensive test first, so everybody's getting the PCR, you're able to split those into 3 categories: completely negative, negative but positive but no toxin detected, positive toxin detected. So you get a little bit more information out of that than you do with the others. But I want to bring up that toxin test because as I think about it, I come back to this. This is the same graph more or less that you guys saw back when we talked about COVID and separating between COVID disease and COVID infection, asymptomatic infection. It's the same situation that we have here. Oops, let me go back. But this time we're looking at toxin production down here. So here's the results for an EIA. And remember, this dotted line is completely fake. The only thing we really know is that for this particular assay, and I'm using this Quick Check Complete assay right here, their limit of detection is 160 picograms per mil of toxin. So at that point, they're 95% sensitive. And the sensitivity is going to drop off as lower and lower concentrations of toxin. And it'll inch up a little bit as you get to higher levels of toxin. So what I really want to know is what level of toxin is consistent with active symptomatic disease? How much toxin do you have to have there before you're really going to be certain that this toxin is causing symptoms? And the truth is, we don't know that. We don't know that. So let's say, for example, that this is true C. diff disease. If you're up here, you're going to have disease. If you're in here, maybe, maybe not. And if you're down here, very unlikely that that's going to be enough toxin to cause symptoms. Whereas if you are asymptomatically colonized, it's kind of the other way around. So my question here that I would like somebody to figure out is, if this is my sensitivity right here, where's the best cutoff for separating out true C. difficile disease and asymptomatic colonization? And is it possible, after all this that we've gone through with all these different tests and all these different algorithms and stuff, that perhaps the very best test is actually the simplest? Perhaps this low sensitivity of toxin is actually because at low levels, that's going to be inconsistent with disease. So we've gone through this huge turnaround here of going through different things, trying to figure out what works best. And maybe at some point, we'll get around to saying the simplest method is actually the one that's going to do the best at separating out disease from colonization. Let me throw in just a few more things here. I know we're running over here, but I had to bring this up. Smell. There are nurses who swear they can detect patients who have C. difficile from the odor. In fact, I remember one time we had a patient where we did a PCR and it was negative. We called him C. diff negative. The doctor called up and said, the nurse swears he's got C. difficile. She can smell it. I said, okay, well, we'll redo the PCR. They sent us a new specimen. We did a PCR. It was negative. They sent us the third specimen. We did a PCR. It was negative. They still treated the patient for C. diff because the nurse swears she could smell it. There's been a few studies on that. There's a couple studies that said, yes, they can from a statistical significance point of view, but not good enough to be used clinically. And this study right here, it's not really much of a study. It's only like 5 people, but it was not any better than randomly guessing. So there's no I've already told you it's got a barnyard odor. on the plate. It's got a barnyard odor. There's no question that there's a smell associated with it. But is that same smell associated with asymptomatic, non-toxigenic strains of C. diff? Probably so. And then dogs. This is Angus, very famous C. diff sniffing dog. They have trained dogs to sniff out C. diff. This study down here mentions that the data there shows that they are pretty good at it, but they're not as good as PCR. So I don't think we're going to have C. difficile sniffing dogs. It would be really cool. I mean, there'd be so many diseases that we could get dogs to sniff out. Couldn't you just see us, having, 50 different dogs walk through the hospital detecting 50 different diseases? That would be so cool. Anyway, so back to my conclusion, there is no great laboratory test for diagnosing C. difficile. None of these tests are all that great. You have to be able, it's evidence, but it's not fantastic evidence. So you have to take into account the clinical situation, which makes, I can't talk about C. diff without going through this. The appropriate ordering. I'm sure you guys have all heard this before, but all of these things that we really want to make sure of before we even order the test. These things are suggestive. Has there been any prior antibiotic exposure? It doesn't have to be. Sometimes people get C. diff without any antibiotic exposure. Hospitalization, of course, ups the odds. C. diff tends to be associated with a high white count in blood, but also stool white blood cells or fecal lactoferrin if you do those. Here's one, symptoms. The patient must have diarrhea. There's so many times, we'll have somebody order a C. diff test and the specimen will never show up in the laboratory. And we'll call them 3-4 days later and say, are you going to send this? Well, the patient hasn't pooped in 4 days. Well, then they don't have C. diff. Okay, just cancel the test. And another big one, laxatives. People will give a patient laxatives and then they'll diarrhea all over the place and send it for C. diff. And then, of course, in the laboratory, you have to look at this stuff. Liquid or loose stools only. We use the Bristol stool score scale of, we're only going to accept it if it's 5, 6, or 7. Some places will use the stick test where you put a stick in the poop, and if it stands up, then it's no good. It's only if the stick falls over. I don't like the stick test, which is unusual for me because I usually play with poop more often than that, but I don't think it works very well. The guidelines are 1 specimen per diarrheal episode. And what they mean by diarrheal episode is if you come in and get diarrhea on Monday morning and we test you Tuesday and you still have diarrhea on Wednesday, we've tested you 1 time during that whole course of having diarrhea. That's all you do. This was a big problem for our physicians because we were used to telling them C. diff times 3. And now we're telling them, no, 1, only 1 and quit. Laboratories can't really police that. We're not going to look up every single patient to see how long they've had diarrhea. So all laboratories will do something. They'll say you can only have 1 test every 7 days or 1 test every 10 days. Some laboratories will actually separate that out. If you've had a positive, then you're not allowed to have another test for 30 days. So different laboratories are able to do different things. And no test of cure. The test of cure for C. diff is that your patient's symptoms get better. You don't want to go in and a week later say, oh, look, you're great now. Now your Bristol stool is down to 2. We're going to test you again. No, the lab's going to reject a Bristol score of 2. And there's no point in doing the test again. The PCR in particular may be positive for quite a while after that patient's symptoms get better. So it's a complicated disease. It's a difficile disease. And I wish we had the perfect test for it, but we don't, and we rely on physicians and nurses to kind of help us out in making sure that the ordering is as appropriate as possible. And I'm sorry, I talked for too long, but that's what I got. So
this was great. This was great. So thank you very much. So I don't see any questions yet in the chat, but I'm sure people are thinking about, okay, how will I use this information? How do I take it back to my facility? But I want to kind of follow up a question that Dr. Ramirez raised last week. And last week we were talking about the use of simulation and education and training. And Valencia Brown was the presenter. And at the very start, she mentioned the fact that since the pandemic, since the early part of 2020, throughout 2020 and into 2021, virtually all of our healthcare associated infection rates have increased, with the exception of surgical site infection and C. difficile infection. So, I know that there are a number of hypotheses about why did we not see an increase in C. difficile when, we had a disease and probably a lot of antibiotics were used and so forth. But I wanted to get your take, like from a microbiologic or a laboratory testing perspective. Do you have any thoughts about that?
Yeah, well, I had not thought about that before, but let me make something up real quick. What I thought was interesting no, I don't really have any good ideas off the top of my head to tell you about that. What I thought was interesting with COVID was looking at what it did to other respiratory infections. But, even on something like when we do our BioFire, our respiratory pathogen panel with all the 22 different viruses on it, if you look at the ones that were most affected, it was the ones that were strictly airborne or respiratory droplet infections. You look at viruses like enterovirus and adenovirus, which are non-enveloped viruses that are going to survive longer on surfaces. Those ones weren't affected by COVID much. So, if you just told me what would I think, what effect would COVID have on C. difficile? I would have said not a whole lot at all. And if anything, with all the staffing problems and all the just going off and our brains being elsewhere for such a long time, that it would probably see an increase in C. diff. But if we didn't, how do I explain that?
So like we didn't have any shortage of testing materials.
C. diff was one thing that we had no shortage of.
So we didn't really change testing. Some of the thoughts were that, increased emphasis on isolation, that perhaps, and hand hygiene, perhaps that had kind of a secondary impact. Or, that I guess, one thing could always be that, reporting wasn't done as efficiently or consistently as perhaps other healthcare associated infections, because, if a patient had diarrhea, it could have been attributed to COVID, and, the patient may have been treated in any way, but, it's somehow not gotten into the reporting. But, it's kind of baffling, because something that is so problematic with respect to environmental contamination, but at the same time, primary C. difficile resulting through antibiotic use, you would have thought would have gone up because of the antibiotics. So, I don't know, like you were saying, that the COVID was such a microbiome bully, and push so many other things out of the way. Was there some type of microbiologic impact due to COVID? Did COVID somehow crowd out C. difficile in the transmission?
Right. Well, do you think the decreased numbers, was it a result of actually a physiological difference, reason why people did not get C. diff disease? Was it just not tested for? Was it, I think, I haven't not looked at this, but I'm thinking back, I don't really think we've seen any decrease during all COVID, any decrease in the amount of testing that we did. So if the number of positives went down, then that would seem to indicate that, the people being tested might be a somewhat different population than what we normally test. Yeah. Do we have people coming in with COVID diarrhea that are getting tested?
Yeah, I don't know. I think it was an interesting, finding.
Yeah, having a pandemic like that was really cool. for a little while. You know,
but yeah, not for 3 years.
I kind of enjoyed it for the first month, and then after that, I was done with it. But it's interesting to see the effect that had on so many different things that you wouldn't expect.
Yeah. Yes.
You know, I don't. We did not have any testing difficulties with C. difficile. There wasn't a shortage that I can recall of testing supplies for that. So it really wasn't an issue of we couldn't test and therefore we didn't know. You know.
Yeah. Well, it'll be interesting, and if any of our participants had any thoughts about that, it'd be interesting. Maybe even go back and take a look at some of your data, or talk to your colleagues. It'll be great to even next week, if there's anything that you want to bring back, something that you found or a discussion that you had, because I think this is quite interesting from an infection control perspective. So we'll see. I think the tools and resources that you had in the presentation were so good. So I think if it's all right with you, I would love to be able to post a PDF of your slides along with the recording, just so people may be able to reference those.
Yeah, no problem.
If that is okay with you, I think that would be great. And Dave, thank you for adding information to the chat. Just as a reminder, our partners with the Kentucky Department for Public Health wanted us to bring forward a webinar series dealing with infection control in the hemodialysis setting. So the first one was Monday, or was it Tuesday? It was Monday, I believe. And the next one will be next week. So it will be every Monday for the next 3 weeks. And we will also be posting those for review. And also we will have then a final review and recording. So we're able to provide enduring continuing education credits for those as well. Again, remember that the recordings that are on the YouTube channel. Hopefully this is another example that you can go back, use this quite excellent presentation, get your group around, listen more to C. difficile, talk about how this may change or impact what is happening in your facility, maybe from a micro perspective or maybe from an interpretation or reporting perspective. But I think Dr. Junkins, thank you very much for really showing us how difficult this difficile is and how challenging it is for us, not only from the treatment side, but from the infection control and the reporting side. So thank you very much. And we will see you back next week, same time, same channel. And I think we'll learn from what has gone on at IDSA and have an update about antimicrobial stewardship. So we will see you next Wednesday.